Thanks everybody for having me on. I really do appreciate the time. I am going to go over a few things today. As far as disease state education, we're just going to kind of do a little bit of review on that, what causes thrombus, what it is that the makeup is, and then what some of the treatment options are for each of these disease states. One of the things that we'll go over shortly after this is we're going to have an example of both of our cannulae. So one that we have had on the market for the last couple of years, our Generation 2 cannula, and then show you the differences between what it is that we've done to be able to update this for your Generation 3 utilization. So I'll go through this pretty quickly to get through our disease state review. I'm going to go ahead and click through a couple of these slides. There is a disclaimer here, and I only bring this up because I'm required to by law. The other reason that I bring it up, though, is that in our indication, when we get to this, in our indication, there's actually a space in there that talks about the fact that we are contraindicated for use with severe venous or arterial vascular disease, which seems a bit counterintuitive. But as most of the audience will understand, we're predicated on a venous drainage cannula. Clearly, you wouldn't normally put a venous drainage cannula in a place that has a significant amount of blockage. You wouldn't be able to get it to do its job. So, because of our predicate device, that is what's on there. It is an understanding, however, that we are going to be working in areas of undesirable intravascular material or our newer indication, fresh or soft thrombi or emboli. So moving on, Joe, I am going to give this to you.
Good.
Thank you.
Just say next.
I will just say next. So venous thromboembolic disease is one of the areas that we see utilization of AngioVac successfully with deep vein thrombosis, or VTE. It does list pulmonary embolism on this slide as well, and that's really there mainly as a reminder for what it is that we have done in the past and for what the device was created for. Created by two cardiovascular surgeons for the treatment of PE percutaneously. And once we got it out into a little bit larger market, we found that that's an area that we feel like we really need to take more time to do more development to make a better product before we get there, at least with our experience with our first and second generation cannulae. Next slide. So how is it that we diagnose VTE? You're one ahead of me, Joe. If I get you to back up one for me. Thanks. Oh. Well, then again, maybe I'm one ahead of you. There we go, Virchows Triad. So 3 areas, I'm sure that you guys remember this from years gone by, years of treating patients. You've got vascular wall injury or trauma, you've got circulatory stasis, and then a hypercoagulable state. The big ones that we think of for hypercoagulable state will be factor V Leiden, prothrombin 2210, protein C and protein S deficiencies. Those are the ones that are the biggest that you're going to find in there for your hypercoagulable states from a hereditary standpoint. On the other side, of course, you have cancer, chemotherapy, and things like that. Vascular wall injury, that's pretty self-explanatory. I'm just going to let that one go. And then circulatory stasis. You can think of your patients after surgery, after bariatric surgery, after some of the others, where they're just laying flat for a long period of time. Perhaps their anticoagulation isn't as effective as they'd hoped it would be. You end up with a potential problem for the creation of venous thromboembolic disease. Next slide, please. So we're going to diagnose this with relatively standard procedures, right? Ultrasound, blood tests, things like this. The blood test that we're going to use likely is going to be a nonspecific test like a D-dimer or something like that to determine whether or not they've got a clotting process going on. And you guys, of course, will be seeing all of these things as we move forward through the process. Next slide, please. So early treatment and early diagnosis is one of the things that you really want to do with these patients. And when you think of venous thromboembolic disease and you think about the patients who you may see with this, it's one thing to get somebody who's my age, Joe's age, up where they've had a significant amount of issue with clotting over the years. And just to kind of review really quickly, once you develop a clot in a vessel, in a vein specifically, what you're trying to do is you're trying to relieve that thrombus from that area early so that you can preserve valvular function. It is the malfunction of the valves through distension, through fresh clot process, through clot formation becoming more chronic that prevents the valves from becoming effective. So what we want to do is we want to treat those early. So if somebody like Joe or myself comes in where we've been abusing our bodies for more than 50 years, at least in my case, I'm not going to speak for Joe, we may not have as big of an effect on this, at least in the long-term sequelae. But in the short term, if you're looking for relief, we can provide that relief. In those patients that are younger, where you discover early on that they've presented with things like swelling and warm legs and redness and things like that, we have an opportunity to be able to really have a a long-term changing effect by evacuating that thrombus before it has a chance to be able to set in. I do want to mention just a couple of other things. IVC filters, something that is becoming less and less in vogue in this country. In 2014, there were roughly 250,000 IVC filters placed in the United States.
Wow.
If you compare that to Europe and others, they placed about 9,000 in that same time period. Now,
Wow.
there is going to be a difference in population. There's some other things that affect that number clearly, but they also are a little bit less aggressive with their utilization of IVC filtration.
That's a pretty big spread, 250 to 9,000.
It's a big spread. And one of the problems that we have in here is that when interventional radiology is the one who are putting these in, oftentimes they don't own the patient. So we lose our patients to follow-up, which causes them to stay longer and can further propagate the issue. I won't hit these any longer because we do have a few more slides to get through, and I love death by PowerPoint just as much as anyone else.
Take
Next
your time.
slide, please. All right, so this is the first setup slide that we're going to have for your ability to be able to log in and register what you think ought to be done for this particular patient. So, right ileo cable thrombus extending to the renals. We're going to have an image of this shortly. It's a 65-year-old male with a history of bladder cancer, cystectomy and reconstruction, thrombus noted on the follow-up CT scan. I'll let you guys read the rest of this. I love it when people read to me as well. So if we can go to the next slide while we do this shortly. I just want to give them a chance to read.
What was the last thing? A small PFO?
Let's go back.
Let's go
Small
back.
PFO present on TEE. Let's just cover. That's a
Okay.
great question.
Okay.
So why would anybody be, here would be something great if you've got a free text ability to be able to put this in on the answer, but why would anybody
They do.
care? Well, why would anybody care then? And we can actually cover this in the post-discussion if that'd be okay with you.
That'd be great. I think so. Yes. Take
So-
a note of that. if
So
you would.
let's come back to this, and we'll do the small PFO. We're talking about somebody who's got IVC issues, and now we're going to talk about there's a PFO present. Why should someone care? And I'm just going to leave that pearl. That was a great question. Thanks for bringing that up, Steph. I'll leave that pearl, and we'll go ahead to the next.
Okay. So in this, now go to Slido, and this is where it's an active poll right now. So
And let's give one more. Let's give one
Mark,
more click.
take it away. One more click.
Let's give one more click, and this will show
There it
us
is.
the actual live image. So this is that patient. This is what we were looking at before. And what we can see is that we've got venography here. It looks like likely digital subtraction. So you've got that in the background where you can really, really see the contrast go through. And then the area, I'm without a pointer, but I think pretty much everybody's going to be able to determine the area that is not smooth and clean and normal filling with contrast, and that would be the area of clot that we're looking at in this patient. So I believe that on your questions that you have that you can answer, it's going to ask you what would you do, and what would you do? Would you put this patient on lytics? If so, what are the potential complications of doing so? Not only relative to the lytics, but relative to the disease process that you're seeing here. Would you do heparin or low molecular weight heparin? Would you try to do this open? Is there a percutaneous option? I'm going to love to see what the things are and what the discussion is after we get through this. But in the interest of time, and I don't know how much I have left, let's continue forward.
Don't rush.
Yes.
Take your
All right,
time.
great.
You're not in a hurry.
So but still, let's move forward and show what we did in this case. So we're going to go to the next slide, please.
Okay.
So, general anesthesia. Most of the cases that we do are done under general anesthesia. Not all. It is our recommendation for any of those cases that are going to happen in the IVC space. Those typically are our longer cases. If you were to look at cases that happen in the cavoatrial space through to the pulmonic valve, those cases normally stick to stitch are about an hour to an hour and 10 minutes. And the average pump time on those is roughly 4 minutes. If you flip over to these cases, your IVC cases, these last much, much longer for a variety of reasons. What's the makeup of the clot? How long has it been there? Is there the presence of an IVC filter? How far up does it extend? Do you have areas to get access? There are just so many more things that come into play with our IVC cases. So with this one, an 18 French reinfusion cannula, I will say that the reinfusion cannula we recommend to be used is an arterial reinfusion cannula, shorter, good for percutaneous access, relatively good for percutaneous access, to be placed over a stiff wire, and it works very, very well for us to be able to get our flow rates, which our goal is between 3 and 5 liters per minute. Now, I do want to take just a couple of seconds in this space as well. So, The minimum size that we recommend, actually that we were tested with, is 14 French, but the minimum that we see utilized in the field today is a 16 French cannula, and that's really as small as we'd like to go where patients will tolerate it. The reasons are fairly obvious, flow rates. Also, the 26 French Gore dry seal. That sheath is a significant, 26 French, obviously it's very large, but also its obturator or its dilator is very, very stiff. So if you happen to be in a case and you can be the extra set of eyes until one of our guys is either there or is working with perhaps with someone else, these all need to go in over a super stiff wire. The tendency of the wire, a softer wire like a Benson or Rosen, something that doesn't have much body, the dilator could actually prolapse that wire and cause you to track right outside the vessel, an extravascular presentation of the sheath. So Amplat super stiff or a Lundquist wire, fantastic for utilization for these cases. I am going to mention the last thing. Everybody's had plenty of time to read this setup. The IVUS showed completely clear. So intravascular ultrasound is one of the things that we find used in these cases sometimes. Personally, I'm a huge fan. Less contrast is better. Less rads are better, so less gray is better. So you have the option to view live in real time exactly what the effect of your treatment strategy is going to be in the utilization of IVUS. And you don't sacrifice renal function or the exposure to significant amounts of radiation under fluoro when you're able to use that. So let's go to the next slide. This next slide, which I think I advanced one further. There we go. Joe, I believe that yours is a little bit different than mine. Let's go ahead and run that. So you can see here on our post image, I think I have an older copy. On our post image, 100%, almost 100% of the thrombus is gone. You can see a couple of areas where you got a little bit of different filling, but part of that is likely because you do have inflow from the left common iliac that's changing a little bit of that presentation there at the segment where, at the confluence where it meets the IVC. So if we can go to the next slide, you should be able to see exactly what the material is that we're able to take out.
Wow.
Now, this is worth mentioning. In our indication, it clearly says that we are indicated for the removal of fresh or soft thrombi or emboli in vessels, well, and then added on to that, not in the IFU, is in vessels including but not limited to the SVC, IVC, the iliofemoral system, and the RA. We're considered to be on label for utilization anywhere in the venous system from basically where the cannula will get, which is about the level of the inguinal ligament, up to the SVC, and then in and through to the pulmonic valve. All of those are considered to be on label. So, but this is clearly not fresh or soft. There is a significant amount of chronic thrombus that's sitting in this space. So, because our goal is to find and treat fresh or soft thrombi or emboli, we can do that. But some of the imaging modalities are not really going to tell us whether or not what we have is fresh or has a chronic component to it. Fortunately, many of the cases that we've done to date have shown this, and we've gotten a great result out of these. Got not only the fresh thrombus, but also some of the material comes in that has a much more chronic presentation. One of the options that I believe that you guys had in your poll was, should you use lytic therapy? And we may have talked about that for just a second. We'll go back to this whenever we do it during the discussion and talk about lytics in this presentation and what we think may have happened. All right. Next slide. So now we move on to a new disease process. If I can get you to click again, Joe, it's going to drop a couple of notes. Perfect. So infective endocarditis. You guys know that by the name, this is literally an infection of the endocardium. The majority of these, there are roughly about 15,000 cases of infective endocarditis, new ones diagnosed in the United States every year. It's most likely been associated with advanced age plus other medical procedures and or pacer lead long-standing line presentations. You guys have all seen the news, and you know that what we're looking at now is an opioid epidemic, and to have those infective endocarditis, IVDA, infective endocarditis patients show up is something that we're seeing more and more, not only here, but also here in Canada and in Europe, which are the three places that we have the majority of our utilization of AngioVac today. The most common organism that you're going to find for this is Staph aureus, is the causative agent, and the goal of therapy is the same, right? if you once you identify this, it oftentimes doesn't just happen on one valve. It's happening all throughout the heart. Tricuspid valve, interestingly, is involved quite a bit of the time. And the formation actually begins at the leaflets where they close first and then work their way back as the disease progresses. Now, if we can move forward one also, and one more time, please. Great. So, clearly the reason that we want to be able to treat this and to figure this out is because of this embolic events. Now, we're not saying that if you treat this disease process using AngioVac as an example, that we're going to change the course of treatment as far as antibiotics are concerned. We're not trying to make a claim today that we want you to treat for less time or with a different antibiotic. We still want you to do blood cultures before you get started. We want you to know what organism you think it is that you're treating. Get them on antibiotics and see what we can do to be able to relieve the sepsis. And there are other benchmarks that we look at, not the least of which being the size of the vegetation that's there. HRS 2017 says that 2 centimeters or greater is when we should begin to address this problem. And we'll talk a little bit about that when we get to the imaging portion of this as well. So the mortality is the thing that we really do want to address. A lot of times, we kind of joke around with what we're going to do when we talk about infective endocarditis. I don't want to say we joke around, but we talk about removing of things that have material on them. It's the embolization of that material that causes long-term problems, anything from septic pulmonary emboli to pulmonary abscess. And if we could avoid that, and more importantly, avoid the estimated, as we show up on the slide now, 15 to 20% mortality rate, as high as 30% in some cases. If we could cut that mortality rate by 50%, based on the fact that we can help to remove the material, we can make your antibiotics more effective, which we'll cover shortly, maybe even change the scope of antibiotics that you were given based on a blood culture. We've seen some of this as well. If we can have that kind of an effect, that is our goal. We want to reduce mortality rate in this space. And for this particular population, I think we can have a huge impact. A huge impact on
Very
these guys.
interesting stuff.
All right, so we'll continue on. So treatments today, antibiotic therapy. And go ahead and give me another click there. Perfect. So many of the cases that are done today are managed with this, with antibiotic therapy alone. If their sepsis is getting better, if their vegetations on echo or whatever imaging they're using are shrinking while they're using antibiotic therapy, we're not asking that anybody go and try to utilize AngioVac or another product to be able to remove that material. It's when these things fail that we would like to see, that we want to provide you with an option other than open to be able to treat these patients. Let's go to the next slide. So one more click. Perfect. 40 to 45% of the patients undergo surgery. And early surgery should be considered with the following, and you guys can read that list. When you look at the Rhythm Society and what their recommendations are when they talk about, and I want to hold off on a little bit of these things until we get to the CIED. So some of the bugs that you're going to be treating are a little bit worse, obviously, than others. But one of the things that is impressive, and let's go to the next slide. I just want people to be able to read this one, and then let's move on. Here we go. Endocardial injury, perfect. Sterile thrombus formation. Let's stop right there. So if we're approved for fresh or soft thrombi or emboli, how can I possibly be up here talking about vegetation? And the reason is because of this sterile thrombus formation. When vegetations begin, as you guys likely know, they start out as a nidus of platelets and fibrin, which is the base makeup of clot in the venous system. Having the ability to be able to consider this on label, and really everything up to the pulmonic valve to be considered on label, allows us to be able to treat this in an on-label fashion so that we don't have the same constraints and the same issues that you may do when somebody's trying to use a device outside the scope of the indication. Next click, please. Bacteria with the bloodstream seed the thrombus. So that's basically the next step in this whole thing, is that once the bacteria starts to attach, they've got a place to attach. And if we click forward one more time, I believe you're going to see the image to this right change to what it is that we actually see inside the body once you open it up. This is not an innocuous process. Next slide, please. This vegetation that's on there, let's go ahead and click again. The vegetation that is on there causes damage to the valve as well. So it isn't just sitting there like you might see a little bit more commercialization kind of show. Incidence, as an example, the AngioVac cannula was used in a short series of patients done at a university in the U.S. And the physician who did this study of 40 some odd patients was able to treat successfully using AngioVac as the treatment modality to be able to remove or debulk the vegetation. But in 45% of the patients, the tricuspid regurgitation was worse after the AngioVac case than it was before. A big question that we had around this, because one of the most common questions we get is, are we going to damage the valve? And it's a great question.
The leaflet itself.
The leaflet
you're
itself,
referring to.
indeed. So, and it's a great question. With a circle, the 14 millimeter circle that we have at the end, the funnel opening, it doesn't engage all of the tissue at one time to be able to cause damage. Second, even when you're flowing at 3 to 5 liters per minute, the negative pressure on the outside of the cannula is roughly 30 to 40 millimeters per mercury negative. It isn't until you actually occlude the cannula that you get the really high negative pressures that can remove the material in the first place. So damage to the valve as a result of the utilization of the cannula isn't what we see. Now, the example that I'm going to give is kind of disgusting, but I'll give it anyway. And if you think of the vegetation being there and removing the vegetation be kind of like removing a scab, I know that's gross, but really you're just unroofing perforations that were caused by the growth of this infectious process on the valve in the first place.
That's why you have the insufficiency.
Which is the worsened, accounts for the worsened TR.
Yes. And when you look at infectious, you know, I mean, in wounds, we've all had them, you know, of some sort, especially you've seen staph wounds in the hospital, at how it just eats the tissue. And so it's going to do the same thing with the leaflet.
Absolutely.
You know, it's a very hostile environment.
Yes, sir. And part of the other thing is that we're sending antibiotics to be able to treat this area, a tricuspid valve, which is radically ineffective. And part of the reason that it's ineffective is because of the makeup of the valve itself. There's not a large blood supply. So the antibiotics that you're giving are washing by as opposed to
by.
Yes, exactly. As opposed to innervating the material that we're trying to treat in the first place. So what we see with AngioVac is that in addition to having this grow, you also have a film on the outside called a biofilm, and that biofilm serves as a protection from the antibiotics that are going by.
Yeah. Not to mention the leaflet doesn't have it's not highly vascular.
Exactly.
Right.
Exactly.
Yeah.
So if we can debulk, disrupt the biofilm, take a large portion of that out, we see a couple of things. One, we see in some cases, and this is case specific, not a claim of the device, but case specific, we've seen patients who are septic on pressors, intubated, within 24 hours relief of off pressors, extubated, with significant relief of their sepsis, right? The pressors are gone, they're all extubated, they're significant relief of the sepsis, and we see that in some cases. There are other cases where actually in the short period of time afterward, that the sepsis has actually worsened for a period of time before it got better. So we do see both, but it is more frequent that we see a resolution faster than it is a worsening of the sepsis prior to resolution. One other thing I do want to mention, and it has to do with infectious disease. One of the questions that we get quite often, especially when we're talking about involving ID, is how is this going to change my practice? Right? If we're going to engage them, they want to know, why does this make any difference to them? And in some cases, we have taken the material, we capture it in a filter, we then send that material to the lab, and then the lab does their culture directly on the material as opposed to the blood. And we have had instances where they grow out between 1 and 4 different types of organisms that were found in their blood, in the
Blood culture.
Blood cultures, thank you very much.
No problem.
In the blood cultures. So it really did change the practice of the person who was in ID.
Absolutely.
They were treating Staph aureus, which they found, and they found 4 oral flora under the biofilm and the actual material. Completely changed their scope and what it is that they wanted to do.
But debulking it in itself, I mean, you're reducing you're greatly reducing the risk of embolization.
Exactly.
So just on its own merit, it would change. You're improving the potential survival of your patient just by this alone.
Yes, sir.
From embolization. Yeah.
That's what we're
and
looking
then all
for.
the other bad things you talked about with pulmonary infection, you know, having an embolus there and then getting a roaring infection in your lung.
Yes, yes, exactly. So if we can go to next. Great. Now this is another one where you're going to have your live pole. And
Oh,
I think
yes.
I think they're setting that up. now.
So that's right. No, right. So take down the first poll. So everybody that's watching, now go to Slido. Still under PerfWeb 31. The new live poll will be referencing these next few slides. So let's take the one down and activate that one.
All right, so while they're getting that running, tricuspid vegetation measuring 2 to 3 centimeters. I do want to mention really quickly, we talked a little bit about what the Heart Rhythm Society or HRS recommendation is for removal. And what they say is 2 centimeters or greater, you should consider removal of the actual material. It has, if you look at our imaging modalities that you're going to find at things that happen at the SVC or really the caval atrial space and through to the pulmonic valve, we recommend and we would like to see TEE imagery. Now, sometimes we'll get a TTE image, sometimes TEE image. The difference is this. With a TTE image, you have about a 70% specificity to the presence of material, but your specificity to size is only roughly 30%. If you take it to TEE, the presence of material increases, the detection of presence of material increases to 100%, but still, the appreciation of size is only at that 70 to 80% mark, and that is dependent upon the skill of the practitioner doing the TEE. So what we, when you talk about whether or not these are good candidates, and you talk about the size of the vegetation that we're looking at, it's very, very important that we find a way to be able to get the best view in multi-planes that we possibly can so that we can appreciate what it is that we're actually going after. There's a paper that I would be glad to find and get to Joe so that he can give it to anybody who's interested, that actually asks the question as to whether or not we should be doing this at 10 millimeters or 1 centimeter. And I don't know what the basis behind that is, whether or not it's because of the underappreciation or whether or not the presence is bad in and of itself. When you look at pacer lead infections, I mean, the recommendation, again, with HRS 2017 is 100% removal of all the device hardware and leads within 3 days of the identification of the infection, and leaving it in past a week or 2 weeks, I can't remember right now which one it was, increases your mortality rate significantly. It actually has a class 1B recommendation for removing it all. Now, it is a non-randomized recommendation. I do want to point that out, and that can be significant. But
That's why it's 1B.
That's exactly right. It's a 1BNR. So pretty impressive what
Still,
it is that you could.
I think anecdotal evidence is sometimes a whole lot stronger. We know.
You bet.
But we'll talk about that. So
absolutely.
We'll
So
go to the next one.
We got it. Yes, history of IBDA, presence not responding to antibiotics with fever. Again, clinical presentation trumps all. We don't just treat, just like they were taught you guys and all of us. You don't just treat the monitor, you treat the patient. We take not only what it is that we see on an image, but what their clinical presentation is and how they're progressing into consideration. So let's go to the next slide. And interestingly enough, it says, "What would you do?" Hopefully, we've given you enough time. Hopefully, we've given you enough time to be able to answer the "What would you do" question. And so with that, we're going to go ahead and go to the next slide. As you would expect, a 26 French Gore dry seal sheath. Anytime these cases are being done, if you've got something that's happening in the RA, tricuspid valve, RV pulmonic valve, it's practitioner's choice, dealer's choice on which approach they want to use. With our new 180-degree configuration that you see there on the screen to the left side, you can actually really effectively get the entire annulus of the tricuspid valve from either an IJ or a femoral approach. In all other cases, if they happen in the SVC, then we like to approach from the femoral up. If it's in the IVC-RA junction and down, we like to approach from the IJ. And the reason is because we always want our device to be in a position of embolic protection.
That makes
Imaging via-
perfectly good sense.
Excellent. Flow rates are 3.4. Again, that's about right where we want to be. Imaging via TEE, again, for all caval atrial space through and even to the pulmonic valve, we'd like to have TEE present. And then a snare to help remove the vegetation, which I'll be happy to talk about later if you'd like. Next slide, please. So click one more time. This is actually the AngioVac during the procedure. So at the top left of the cone, you're going to actually be able to see the cannula come through. You can see it right there. And then as it moves toward the vegetation, next slide, please. This image that you can see, we all know, can you see whether or not if we click one time, whether or not we're going to swirl?
Ah, there it
you
is.
go.
Yes.
So
I see the gradu.
yeah, indeed.
That's a Louisiana medical term. Gradu.
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 So you can see the material floating around, and this is typically the presentation we're going to find when you have something with a varying levels of chronicity. Obviously, if it's more chronic, it's white. If it's fresher, it's dark. But sometimes it becomes very difficult to see whether or not the material has actually been captured in here. It's really easy to see when it's white and it spins around like this. We can talk more later offline or online at the end of the discussion about how to determine once your filter's full and what are some of the cues. But one of the things that you can even see on this image clearly is the swirl of blood within the filter. That is a huge cue. If we're not swirling, we're not flowing. If we're not flowing, we got to start investigating. So it's kind of where we sit on this. And if we can go one more forward again, please. This is the material we were able to remove.
That, yeah. And this is all infectious material.
It is. And for the purposes of this, I would like to go back just to a couple of slides. It may be slide 20. 21, that's it. So go ahead and click forward one time and let's see if it'll roll. Now you saw the vegetation that was sitting on the table there. The vegetation measured in up to 5 centimeters, I think, 4.5 centimeters. On this image, would you have guessed that you have 4.5 centimeters of material?
No.
No.
This illustrates the point that I was bringing up earlier, which is skill of the practitioner, rotating the probe, making sure that they're able to see as much as possible, makes a huge difference in evaluating what it is that we see. All right, let's go to our next slides, please. Next. Excellent. Perfect. So one more click, if you would.
Help me out.
There we go. So cardiovascular device infection. I got the opportunity to be able to talk a little bit about this beforehand. So what I want to do a little bit is just kind of go through the what our goal is, right? Today, whenever you identify material on a pacemaker lead, one of the things they like to do is something that I like to call pull and pray. Pull the lead.
Pull and pray. That was an option in the poll.
Oh yeah, yeah.
I want to see if somebody
I wasn't
picked
going to
pull
see.
and pray.
I was going to let that one go. See if they were paying attention. That's awesome. Yes, pull and pray is one thing, and when you talk with interventional radiology, they'll tell you that the lungs are the world's greatest filter. I've heard that more times than I care to count. But to a certain degree, it's the God's honest truth. You can just send something if you have normal PA pressures, et cetera, you can send something to the lungs. It'll either dissolve or a patient will do fine. When you look at this material, because it's infectious, we talked a little bit earlier in our tricuspid section about embolization of material and the possible for septic pulmonary emboli or for a pulmonary abscess. When you do a pull and pray, the problem is that the issue doesn't show up while they're on the table. The issue shows up 3, 6, 9, 12 months later, where their mortality rate, again, is going to show up as high in some papers as 20 to 30%. If we had a way to be able to remove that material to allow you to extract the lead while reducing the probability of embolization of material, everybody wins. And that's really what we're out for. It's always patient first. We want to see what we can do to be able to help this mortality rate and help these patients do better. So it's worth mentioning also that there's a heck of a lot more of these to do today. Back in the day when our life expectancy was only 65 to 68 and they weren't putting pacemakers in until 65, well, there wasn't a lot of opportunity to be able to have a generator change. And while the infection rate is only 1%, let's go to the next slide really quick. It's only 1%. Let's go ahead and click next. 7 million devices placed annually, 1.4 million leads worldwide. That's a lot of leads. And when you look at our things on the right, they're being placed when they're younger, the populations are living longer, more upgrades and replacements. And the reason that upgrades and replacements are important to mention is because while the infection rate on an initial placement is only about 1%, on reimplantation it goes up to 3 to 5%. It's a significant number of people who can be affected by this, and this only speaks to 2 of the areas. Really, we focused on IVDA, and now we're focusing on pacers, cardiac implantable electronic devices is what we're focusing on. But in addition to this, you also have long-standing dialysis lines, long-standing port catheters, long-standing PICC lines, things like that, where an option to be able to remove significant amounts of material that can cause a pulmonary insult that may negatively affect the patient we have an option for you. All right, let's move to our next one.
Before you do,
Yes.
I can tell you right now, my mother's 100. She just turned 100.
Oh, wow.
And
Wow.
just had her 100th birthday, healthy as could be. And if she had a line in her, and somebody told me they were going to pull and pray, and that's the problem, is that the general public is, though we have Dr. Google, they're really not that well informed. And if you have this infectious lesion on your lead, and your doctor says, that's okay, we just pull this out and the lungs will just catch it, it'll be fine, they don't know any better. No. But I can tell you right now, I'm not going to have that happen to my mother. I'm not going to have it happen to me. You know, I wouldn't even let it happen to you.
Thank you, Joe.
You're welcome. You're welcome.
We're becoming fast friends.
Yeah, right? This is working out well. And this actually goes to exactly what you're talking about now. If you look at all-cause in-hospital mortality, device-related infection, up to 4.3% now. I mean,
Wow.
it's kind of, it's on the rise. We want to be able to provide something that in a study-based environment allows us to be able to prove what it is that we think that we're going to be able to do. To Joe's point earlier, anecdotally, we want to show and prove that what we're doing makes a difference in the long term in the mortality of these patients by making a reduction in that. And we're working on those processes now within our own company to be able to begin that study.
Yeah, sure. And the
as well.
DRE with renal insufficiency is so high because you put these people on all these high-dose antibiotics and you kill what's left of their kidney and they're in full-blown renal failure at that point.
Something else. Okay, if we can go to the next slide, we're going to get to our final case presentation. So I think they're going to close the poll for the last one.
Okay, is this the one we go? Okay, so let's close that poll, open up the new poll. So all you guys, if you haven't already voted, we got to go to the next poll and get on and do it on this one. And it's going to be number 3, referencing slide 26 and 27. And it's another what would you do?
Indeed. Thank you, Joe. So, right ventricular lead with vegetation in the RA and on the tricuspid valve. On this one, I'd like to know for our case discussion, if you saw this presentation, RV lead vegetation, 70-year-old male, hypertension, diabetes mellitus, coronary artery disease, MI times 4, and EF at 10%, presents with sepsis secondary to RV lead vegetation. If you're looking at this, what are you looking at? What are your concerns? What are your questions that you'd like to have answered before you proceed with any kind of therapy? And be able to get an answer to those things before we move on forward.
I mean, is this a real patient?
Yeah, I mean,
Because that 10% EF
That's
is
a
really
problem.
a big
Yeah.
concern. I would
Yeah.
say at a 10% EF, that's pretty bad. Just for the sake of argument to make me feel a little better, let's make it 20.
okay.
20%. 10%.
They still, you know what? You're going to get a BIV ICD if you're 10
This-
or 20 either way. So you
this-
knock it right out.
Yeah, this lead problem is the least of his problems at this point. But let's see. So we did his lead. He's on. Presents with sepsis secondary.
I'm concerned if you do anything with this guy, you're going to take
Yes.
him over the edge.
He's in
So
trouble.
you need
So
backup.
make him 20%. It's not so bad.
Hold
Oh, I
it.
know what to do. The thing I'm not allowed to say because you're here right now, I have to do it at the end of the show. Yeah, cover your ears. The thing I'm going to show you later would be a good possible solution to this, but we'll go on.
So,
So stay tuned in.
so where were you? So you said one of the big concerns for you is what?
Going in trying to remove it or even pulling the lead could just tip him over the edge of he's stable and okay to full-blown coding.
And
Yeah.
so what's the, so that's a great point. So what's the major concern there, if you don't mind me asking a question, I'm putting you on the spot. What's the major concern there?
I mean,
Hemodynamic
he's
collapse?
gonna, yeah, die on the table.
Yeah, honey, but I mean, it's
I would
hemodynamic
say-
collapse,
Worst
right?
case scenario.
I would
hemodynamic
say
Totally right.
general anesthesia.
Right.
I don't think anybody wants to put him to sleep.
That's a fact. So,
That is a fact.
so in cases like this, and Joe's going to have the opportunity to be able to talk about all kinds of neat things about pulmonary embolism that I'm going to not talk about. But in cases like that, and one of the things that we look at is we look at how well patients are going to tolerate the hemodynamic kill or the change in sympathetic tone by the induction of anesthesia. And I know that's where you're going with this, and I could not agree more. So when we see patients like this, our team is mindful of the fact that we want to talk about induction with medications that don't block sympathetic tone to help be able to maintain the constriction that you have in the periphery, to be able to maintain the pressures that you're achieving and be able to make that happen. But from a hemodynamic standpoint, when you talk about an AngioVac case in general, because we are veno-venous, we don't, in spaces from the pulmonic valve all the way through, because we're pulling and returning at the same rate, we just don't see change in hemodynamics.
Yeah, it's a closed circuit. It's a
Closed circuit, closed system,
yes.
yep.
Yeah.
Now,
you will have some mild, mild hemodilutional effect, but mild.
Mild, yes.
But you could also do a blood prime and fix that. So, I mean, there's ways around it.
there are ways around it. And I'm glad that you brought up the thing about the mild hemodilution. The cannula and circuit, the entire thing primed, is roughly 600 to 650 cc's of saline, or your favorite non-dextrose containing product. The patients do better. The AngioVac cannula performs better in patients who are relatively wet. They're intravascularly full. We are a flow-mediated device. We have to have flow in order for this thing to work. And in order to do that, to the degree that the patients will tolerate it, as much fluid on board as they can maintain inside the vasculature without causing any kind of an issue. That's,
Well, somebody with an EF
worthwhile
of
point.
10% is going to be very volume overloaded.
They are going to be volume
Or
overloaded.
they're not
for
going to
sure.
be alive.
So let's go to the next slide and let's take a look at what it is that we're dealing with. And with any luck, when you click again, you'll get a play.
Oh, yeah. I
So-
see it flopping around there.
Yeah.
See that flopping around, right? So what we have, the hyperechoic, the bright white area that's to the middle portion of the screen is going to be your lead. The other, schmutz is the super popular and very clinical term that we like to use, the material that's sticking to the lead.
Yes.
And you can see some amount of it there. Now, obviously, this is blown up a little bit larger, but if you had to make a size estimate from this, are you going to say this is what, half a centimeter, maybe centimeter, using your markers over on the side, knowing that each one of those is a centimeter? What are we going to do?
I think it's hard to tell on a single plane.
I'm so glad you said that, Joe.
Yeah.
So anytime that we're getting images, our clinical team has reviewed, we've done well over 4,000 cases to date. And we review images on every single one of them. In addition to that, our entire team shares all those images so that the person who's been here the longest, me, to the person who's been here most recently hired 7 months ago, they get to see all of those cases and see all of the experience and share and get all of our experiences together in order to be able to make sure that the product that we're getting to you is going to be the best one we possibly can. Let's go ahead and go to the next slide. So, interestingly
you
enough,
do?
what would you do?
And
Pull
you've
and
got
pray.
Multiple operation. Man,
Maybe
no,
the
not on
right
that
answer.
one.
I don't know. Maybe the wrong answer.
Not
Yeah.
the right answer on this one. If
I
you
don't
pick
think
pull
so
and pray,
either.
go back and change it. You got time.
Yeah, right. All right, let's go to our next slide. So, we talked about the dry seal sheath. We talked about the reinfusion cannula. You can see a 16 was used this time. We talked about 18. We've even used them as high as 20. I do want to take a real quick pause since we're talking about sheaths and cannulas really quickly and talk about the fact that you may find cases where your physician wants to use two 26 French sheaths in a patient like this, as a matter of fact, or a tricuspid patient, which would allow you to be able to change the direction that you're going to go with your cannula. So if their initial approach is IJ, if their initial approach is femoral for a septal leaflet, it may not be able to get there as well as it would from an IJ approach, as an example. Or an anterior leaflet from the IJ may not get there as well as it would from the femoral approach. Our team, none of us are going to dictate medical practice. What we are going to do is share our best experiences with the physicians in order to be able to allow them to have more information to draw from. But in the event that they're going to choose to go with something that maybe we haven't seen work as often, a 26 French in the neck and a 26 French in the leg, as long as you have a reinfusion cannula that's 20 French or smaller, you can put the AngioVac through one, the reinfusion cannula through the other, and then if it doesn't work, it's really easy to clamp, reverse, and go right back on pump and not lose a significant
That's a
amount of time.
very good idea.
So we'll
Very
see
good
that
idea.
happen in some of these cases. All right, snare technique used to direct towards the vegetation. I am going to say that the snare technique that we used to use was really necessary with our second generation cannula, which we're going to go over in just a couple of minutes. With our newer third generation cannula, which is out, which you've seen on all of our slides today, you can direct that 180 degrees anywhere from about 45 degrees all the way to 180 degrees. As a result, we haven't needed to use those snares in order to be able to direct the distal tip of the cannula like we used to. All right, next slide.
I've done
please.
that snare with Dr. Matoyer.
Is that it's?
He did I tell you what, he did a great job with it. It worked.
It's
It
a
worked.
challenging.
It's challenging, but he did it and it worked really well. We presented that case, right? You were there with us, Mike. Yeah.
All right, so if we can go to our next slide, you're going to see what
Oh,
it was
yeah.
that we were able to capture out of
That's
there.
a
Now,
lot bigger than just a couple of centimeters.
It is, and you can see it's present on both sides of this. Now, unfortunately, I don't have an image of this being outside of the filter. I think they ended up just boxing up the whole thing and sending this in. But this is another good illustration of what it is that you see on an image may not be indicative of what actually is present within the right atrium or other area.
Absolutely.
All right, if we can go to the next one, this is going to be the brief, a very, very brief portion, and also will represent the end of this slide deck. So pulmonary embolism, we've got all of the causes that you may have for pulmonary embolism listed on the screen in front of you. That's certainly not an inclusive list, but some of the things that may cause it. If we can go to the next slide, then let's talk about options. So open surgical embolectomy is a great option. We work closely with Dr. Andy Kaiser out of Pittsburgh, who does a significant number of pulmonary embolism cases. He does them open. The patients do well if they intervene earlier. He's able to do things from express clot through actual compression of the vasculature to clamping across the hilum and doing a reversal of flow with the patient on full deep hypothermic cardiopulmonary bypass. Yeah. So he can actually reverse the flow through the pulmonary veins, send all the clot back out through the main PA, capture it, and get a really, really good result. Great option for the treatment of pulmonary embolism. Next, it's going to show thrombolytic therapy. There are catheters on the market today that are approved for placement within the pulmonary vasculature. Giving lytics to a specific area reduces your chance for major complications from a 1 to 3% with catheter directed versus a 10 to 15% with systemic. And you don't have, I don't think, as great a worry with some of the relative, not absolute, but relative contraindications that you may have to lytic therapy otherwise. IV heparin or Lovenox, great for stopping the propagation of further. We all know that heparin and Lovenox don't work to dissolve the clot, but certainly keep it from getting worse. And then oral anticoagulation. I do want to mention also, there was another physician that we work fairly closely with who, in the beginning, when we were trying to work with AngioVac and PE and figure out what we were good at and whether or not we were good in that space, had 10 patients that he came in with varying levels of severity of pulmonary embolism, all of them toward the massive side. All 10 of them, he put CDT in place to drip them overnight in conjunction with placing them on ECMO. Totally anecdotal. I don't know, there's not any good inclusion or exclusion criteria. Having said that, 10 out of 10 were still alive at 90 days with a massive presentation, which is pretty impactful. I look forward to seeing, and AngioDynamics, we are now working on cannulas that will be labeled to work in this space. And I look for that within the next, I'm not going to pigeonhole myself into a time on camera, but it is something that we're working on today, and look forward to bringing that as we continue our research with our opinion leaders and our focus groups to be able to get something that we can deliver to the pulmonary vasculature safely, effectively, and have a great outcome for this difficult patient population. And if I can go to the next slide, I think it says all that needs to be said. Joe, thank you very much.
Very, 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 very good. Now,
thanks, guys.
Excellent work. Now, do we want to, by the way, 100% of the people said they would use long-term antibiotics on your last one.
That would be 100% correct.
I don't know how many yet.
That would be 100%
what
correct.
the number is of the people that responded. So we'll get the other ones. If you can give me just you don't put it up. I don't want to put it up. Just give me the numbers. Or where's Magic? When he comes in, just ask him to get just report the results to me if you could. So do we want to go into a discussion now, or do we want to jump right to Dr. Zlotnick?
How much time do we have before Dr. Zlotnick's on? About 11 minutes?
He's not slated to come out until
Okay, so
Okay.
we
We have
have
a lot
we
of
have
We have time.
plenty
We
of
have
time,
20
so we
minutes.
could just discuss this if you'd like.
I'd love to. Can we, while we're here and have this this platform, can we go through the differences really quickly, just to show you? I'd promised you I would show you the differences between the second and third generation.
Yes,
Yes, that'd be
absolutely.
great.
We have plenty of time to do that.
That would be
Yes, I
great.
would love to do that.
That would be fantastic.
So for those of you watching at home or in your car or wherever you may be at the airport, because of course this is the best program. No one wants to watch fun YouTube videos, right? You want to watch this. This is the best.
Right.
But for those of you, Dr. Zlotnick is going to be coming on and talking about developing a successful AngioVac program in your hospital. I believe that is the title. I want to make sure I have the title correct. It's going to be Building an AngioVac Program. So I think that's going to be very important for you to look at. One of the points that I was going to make is that AngioVac cases count as a procedure for our ABCP procedure counts each year. So this is a really useful tool that is, in my opinion, still grossly underutilized in the market. And so I think this is something we really need to talk about, and perfusionists to get more actively involved. One of the things, Mark, I'm going to ask you for is to help give us guidance on how do we find these patients. You know, we work with heart surgeons. Heart surgeons are going to get the cases if they're referred to them, but they're coming somewhere. And given what I understand about geographical utilization differences, if you will, something that I find odd to me is that how a population that I see here in Houston can be using this so much less frequently than a place like Indianapolis, which has a much smaller population, but a much higher incidence of the use of the AngioVac. So I'm trying to figure that out. So just keep the questions in your mind.
Okay.
But if you want to show us, Jen, what slides do you need?
Actually, I don't need a slide. Just the camera would be fine, and then I just need to step over and just grab a couple of the cannulae.
Yeah, please, go ahead and bring it back here, and then just sit here. We'll zoom in. Can we zoom in on the
Joe.
catheter? Somebody man the camera for
Mike?
us. He'll bring them over
Gen
here.
2 cannula?
Yeah, you can. Duck, Mike. Duck,
and
Mike.
goose.
You were a Marine. I thought you knew how to
All right.
duck.
Army.
Oh, that's right. You were Army.
Oh, that's why.
No, you were Marine. You were a Marine.
No.
Wait a minute. All right. I was Army as well. Come on, man. All right. Where are we?
Okay,
Let's
so
see here,
we can
right?
zoom in on this real good. And
Oh,
so
that's
give us a
fantastic.
second and let us get focused
You
and
bet.
stuff. So they can do a lot of fancy voodoo. Just remember though, your depth of field may not be as far.
You want to come out just a little bit.
Just maybe zoom out a little bit.
A
That's
little bit
tight.
wider.
There you go.
Oh, that's fantastic.
Yeah, that's good.
All right.
And then you got a good focus? Good. Do you need a better
Fantastic.
light on it, or are we good? Okay. All right, go ahead.
All right.
I'm done.
Fantastic. No, that's great. So this is actually,
Oh, I don't have my
this is
glasses on. That's why it's
representative
out of
of actually the 4th generation of the cannula. There was a previous version prior to our company buying it, and that one was a 25 French outer diameter, a different shaped balloon on the inside of this outer bag. And it's worth mentioning because in some instances we've gone to these cases where the facility wasn't able to get a gore dry seal sheath. And because of that, they feel like they have to cancel the case. And the answer is absolutely not. These cases were done 100% via cut down when we first started, and they're still done via cut down sometimes today. So when we're looking to be able to do these, if gore goes on a back order with their dry seal sheath, which just happened a month ago, and has been resolved, but it did happen about a month ago,
Wow.
there is another option. One of the options is a Medtronic sheath called a centra sheath. It's also 26 French. The negatives of that is the fact that it has an opposing slit valve. So one is going this way, one is going this way at different depths within the body of the sheath. It takes away some of the feedback. Because there's constant drag and an inability to adjust the tension on the cannula, there's constant pressure type feedback whenever you're doing these things, which makes it a little bit difficult to get some of that feedback when you're treating a patient. You don't want to push through something when you can't tell.
From the operator's perspective.
From the operator's perspective, indeed. So this is our Generation 2 cannula.
Can we go back? Yeah, there
Here
you
we go.
Thanks, Ben.
So we had radiopaque markers that we added to the distal end. You can see that there's an outer balloon, and the inside of here is an inner balloon that actually works to inflate and separate the petals to create a funnel right there at the end. Now, the more fluid you get in there, up to roughly an atmosphere, one atmosphere.
You want a syringe?
No, that's quite all right.
I've got one right here.
This is going to get so much. Actually, you know what? Joe's going to do this. We're going to put this cannula on the spot. If I can get you. Oh, okay. Is this a trick syringe?
Here, let me
Joe
see
gave me
it.
a trick
Let me
syringe.
see it. No, you just have to.
I think I broke his syringe. At any rate, so we had a balloon on the end. We did have up to a 20-degree angle that we offered before.
Let me see it. I'll give it there.
Sorry. And a stainless steel coil reinforced cannula. Now, some of the challenges that we saw, and Joe's going to blow this up with air.
I'm going to let Tammy do it.
Tammy's going to blow this up with air. Here we go.
Because it works.
Now,
Yeah, see? It works.
there we go. You can see this starting to go in. Now, normally this is done with an endoflator, and we'll get a lot more in there than what we're able to get out of that little 3cc syringe. But what happens is that it would open the petals. Now, further, I'm just going to go right down the cannula. Stainless steel coil reinforced cannula with a quick connect on the back end. Here is our inflation port where we normally would use an endoflator, and this quick connect allows you to be able to rotate the cannula without having to rotate the entire circuit. Anybody who's been around long enough to have seen our first generation cannula, it's kind of like working with a Swan. Anybody who's worked with a Swan, you kind of have to chase them all the way around with all the ports. We wanted to solve that with a quick connect on the back end. Now let's talk about what we tried to change with the Generation 3 cannula. And the good news is that all we changed with Gen 3, other than its location, is everything. So you no longer have a balloon on the distal end of the funnel. Are we right here? There we go. We no longer have a balloon on the distal end of the funnel. One of the challenges that we had with some of the cases that were done with our Gen 2 cannula was that as you inflated the balloon, some of the petals wouldn't expand all the way. This would create an area where a petal could actually prolapse in, and with it prolapsing in, you would have an effect on flow rates and the ability to be able to extract material. Now, there is a nitinol basket on the inside of here. That funnel is the same every time, and it's 14 millimeters.
And for people unfamiliar with nitinol, when it gets warm, it expands. And so as that's collapsed in the cool, you put it through the sheath, it gets in the bloodstream, and it opens up.
And so the way that it's done here, we've now, instead of a balloon to expand our funnel, we actually have an oversleeve. Let me go back into here. There we go. So you'll actually retract the funnel into the oversleeve. That oversleeve will allow you to place a dilator or an obturator and a wire right on through. Once you're in position where you want to be, wire and dilator come out, and then a little quick advance of your cannula, and you can see the funnel automatically expanding, same shape every single time. Now, regardless of approach, on the back end, we told you could approach from either direction, IJ or femoral, and get a very similar performance of the cannula. You can see this TUI on the back end. This allows you to be able to advance the cannula in and through, pull it back, and once you've got the angle you want, you simply lock the blue TUI down, and that'll hold the shape that you want to achieve. So if I'm coming from the neck, let me get back into camera there. If I'm coming from the neck and I need to have, let's call it about a 75-degree, 80-degree bend, we can stop it right there and lock that right into place. And now we can treat, as an example, and we're going to talk about tricuspid on this one, we can get the entire annulus of the tricuspid valve by simply rotating your cannula from one single approach and be able to get all the way around.
Very nice, very nice. You mind if I ask what the stopcock's for?
The stopcock on the back end here is, this is a flush port. So because we now have, it's a great question by the way, now that we have an oversheath as opposed to a balloon, and I'll go ahead and separate the whole thing out. You wouldn't normally do this, but I'll just separate them out so that you can see that you have two completely separate tubes here.
Now I see.
So this oversheath, if you'd put a sheath into the vascular system anywhere, you'd want the ability to be able to pull a negative, evacuate any air, and then till you get a little bit of blood back, and then give a good flush forward to make sure you have a nice airless system.
Makes sense.
That's the whole purpose of this. So once this plops
and then
back
that
in,
one gets flushed via the circuit itself.
that's exactly right.
Right. So unlike that second generation, if you will, this is 3. Your previous generation, that just had the one method for flushing was central lumen.
Correct.
Because it didn't have the oversleeve.
Correct.
Okay.
That's exactly right. So anyway, this is kind of the everything that we've changed. I do want to mention also, while we don't recommend that you ever clamp this, where's my camera? There you go. Where we ever clamp this,
Yeah, with wire.
if you were to clamp it and you were to squeeze this, and I'll see whether or not you can see this, I'll pinch it all the way down, it will
Here,
rebound.
zoom in. Yeah, let's get them to zoom in and let them see that. Do you want a tubing clamp? I can give you one.
No, that's okay. I can do that.
Okay.
We'll be just fine. All right. Wow. It's a scary looking guy on the camera. So just if you would focus on the cannula alone. I'm going to squeeze this, and you can see I can pinch this all the way through and then release, and it maintains its shape.
Oh, yeah, that's good.
If I were to do the same thing with our Generation 2 cannula, sorry, Mike. Go ahead. I can fix it, though. If you do the same thing with our Generation 2 cannula, I'll show you fingers here. I'm going to pinch, and then when I let go, you can see that it held that nice flat presentation.
Yep.
You can fix this. Actually, you do it the same way you'd fix a coronary artery or peripheral artery. You go through with a balloon, and you plasty it open. So we've done that with a non-compliant 1220, gone through and had to plasty it open if somebody grabbed a little too aggressively with the cannula when they were trying to advance it.
So are you still selling these, or it's all converted to Generation 2?
That is a fantastic question. So we are still manufacturing the Gen 2 cannula today. We don't have CE mark yet, or we're not approved for utilization for this device in Europe or Canada. So we're still going to be selling these devices, at least in Europe and Canada. And in the event that there's ever, and you know how it is with the medical device world, right? If there's ever an issue with our ability to be able to manufacture, if there's a back order on any part or something like that that we can't control, we'll have these as a backup for a short period of time. Right now, we've just completed our limited market release of our AngioVac Gen 3 cannula that I just showed. We've done already almost 60 cases. And there has been one case where it did not perform and remove the material. This patient had prior to us, lytics, ecos. They had, what's the cleaner wire? They had the Inari, clot triever or flow triever. All of which tried to go in and have an effect, none of which did, as it turned out.
Too chronic.
It was way too chronic. The patient
Calcified,
had, well,
fibrotic.
it was renal cell carcinoma.
Oh,
So it
okay,
was
well,
really, really thick,
Yeah, that's bad.
very
That's
hard
bad.
material that was
That's a
we
huge,
weren't able to extract.
huge problem.
Yes,
Huge problem.
So that's kind of the differences between the two cannulas. Again, I kind of make a joke out of it, but it is true. The good news is that the only thing we changed is everything. It's very much easier. It's so much easier to use, so much easier to set up, and we are seeing, in addition to that ease, fantastic results with our cases. So very excited about this product, and are already working on our 4th and 5th generations of the AngioVac cannula and circuit.
Okay, so let me give you some very interesting information.
Okay.
On question 1, 100% said open thrombectomy. For number 18.
Wait, Joe, can I stop you? Can
was-
we get a
yeah.
brief reminder of what the first
8
one
was that iliac thrombus. Remember that iliac thrombus in the was 100% was open thrombectomy. For
Okay.
question 2, which was question 2?
Question 2 was the tricuspid
The
endocarditis.
tricuspid, 100 long-term antibiotic therapy.
Okay.
And on the
Which, by the
final-
way, is the correct answer.
final question, no, it wasn't.
It's a correct answer, but it's only a part.
And it won't do it. Would you like to reset poll results? No.
Oh, do you need to close the poll? Did we
Oh,
close the
yeah.
poll on that
There.
one?
Yeah. Yeah.
View results? No, it won't give it to me. Can you guys help me out and just tell me what it's supposed to be? Oh, there it is. 100% is long-term antibiotics. The same. I got it. Never mind. I'm sorry. Same thing. 100%.
So,
So
interestingly,
it seems like we have consensus.
well, in the consensus so far,
I don't
on the-
agree with any of them. I think all of you were wrong, but you know, I mean, nothing like complimenting your audience.
So there's only one that I would consider a little bit outside what we might normally find, and that's the one that says open interruption for the Ileo cable thrombus. It is open as you might get, likely if they weren't going to use AngioVac, which in this case we clearly did, If you're not going to use that, then likely what they're going to do is they're going to start with a lytic therapy. They're either going to use systemic or probably catheter-directed thrombolysis. They may use angiojet. They may use ClotTriever. They may use FlowTriever. There are a multitude of devices that are on the market to treat VTE. And all of them have their place. I mean that. All of them have their place. The benefit, the thing that we like about the utilization of AngioVac is the fact that you get the estimated blood loss per case is roughly 50 cc's. And that is only as a result of what you have left in the circuit when you finish, because again, you live one-to-one reinfuse. The next thing that's a huge benefit is that other products either depend on another product to be able to melt the material that's there, lytics, or they fragment the material to be able to pull it out. I'll use angiojet as an example. That fragmentation can cause some significant issues, not the least of which can be distal embolization. So our goal with the large bore and the large funnel is to remove things whole or en bloc, to decrease, not eliminate, but decrease the probability of embolization material causing a further problem.
Well, and in case 1, don't we want to discuss the small PFO?
We do want to discuss a small
We
PFO.
do want to, okay.
Is there
so-
anybody, is there a way to be able to get a live? I'm going to let you guys discuss. Why would we care? If there's, it's all the way down here. Why does it even say anything about a PFO?
We recently had a patient that had history of PE, DVTs. It moved, and it was in the right and left atrium.
Okay.
So
Yes.
crossing
That's why. I
over
mean,
is
it's
a
That's why you
huge-
care.
It's for us. It's somewhat intuitive. I'm not sure. I would hesitate to think that any perfusionist wouldn't know that answer.
So that's a great point. So, but there's something else that we have to consider. I know that you guys work in this space all the time, and I know that
And
you're
you
going to
said
know
it
the
was
answer.
a left to right. It was a left to right shunt, but it doesn't matter.
No, it's a right to
clot-
left.
Right to
It's a
left.
right
It was
to
a right.
Right
I thought
yeah.
it said not a right to left
it-
shunt.
I don't.
Can we?
Can we
I
go
know
to
it
that
said
slide?
right
Can we
to
put his
left.
slides back up? Go to slide.
Honestly,
Here,
I
I'll
don't
do it.
remember which one it
Yeah,
said
just
either.
go to slide
I
one.
wrote right to left.
I
But
did too. That's what I
No,
said.
go to slide one because I'm positive, but we're gonna check.
Always positive.
ooh.
I'm positive. Here,
Uh-oh.
I'm gonna go. I'm
True-
flipping through
Trulux-
it. Here,
Trulux
there.
dinner?
Start it back up again.
Trulux
Trulux
dinner?
dinner.
Dinner.
Trulux dinner. Trulux
Okay.
dinner.
For us, not just
Yes.
for you. Okay.
Yeah.
Bet.
No, I
What's
get
the
to go
bet?
to.
Wait a
can-
minute. Is there
can
a
you-
True Steak and Stone Crab?
I need to
Yeah.
go back.
Oh, yeah.
Oh, we can skip all that Lupe stuff,
Lupe.
y'all. We can skip some Lupe.
Tortilla,
I didn't realize there's a True Love.
Here.
It's the-
Just turn them on. I'll flip through
The
it.
case,
Doesn't matter.
The first case study. It's slide
just-
8.
just-
Slide 8.
It just
Well, that was the photo.
Oh, okay.
Wait,
well, it's
right
right
before
before
that.
that.
Seven.
Right
One before.
Right before 7.
okay. Hold on. I got it. Small PFO present without right to left shunt. Through Lux for Joe and a guest.
And the guest.
If anyone from the audience calls in, asks
in.
a question, sends a good text question, something,
I won
then
last
you will be my guest.
Damn.
Stephanie gets to pay for me. Tammy gets to pay for you.
It was
Done
you
deal.
first. I thought I was sure it was going to be me.
So would you consider, to be safe, closing that before you start?
Closing the shunt? No,
Yeah.
probably not. I would just
'Cause
make
they
sure
can
that I
go
had.
in and pat-
No, you would just want to go superiorly, or put a filter in if you want to go inferiorly,
Which is recommended
and make sure it
anyways,
gets
right?
It's recommended
protected.
anyway.
The whole idea is to protect it from getting into the right atrium, because
Of
once it gets
course.
in the right atrium and starts tumbling around, even though you don't have a right to left shunt, you still have the possibility that it's going to make its way over there vis-a-vis the case that you just got through
rubbing
doing.
it in.
Yeah, he is. He is.
So,
Right on.
There you
without
go.
the right, and thank you very much for bringing that back up again. Yeah.
Yes.
So without the shunt, anytime. So when we're looking at the imaging and we're talking about the imaging that we get for these things, we talk about getting a TEE for all cases that happen in the cable atrial space and through to the pulmonic valve. One of the things that we always look at is the location. There are 5 indicators that we look at when we're looking at right atrial cases in any of these things to be able to determine whether or not they're good cases for AngioVac. Location, size, mobility, and being able to determine the mobility from heart wall mobility versus the actual motion of the material. Density, and then the 5th one, which I'll remind you of in just a minute because I really want to get back to the other, and that is location. Anytime that we get an image that shows material moving and we cannot see the intraatrial septum, and there's a lack of motion in that space, that is material that is crossed to PFO until it's proven otherwise. We always make that. We always make that assumption. So especially if we're able to see an area of attachment at the intra-atrial septum, stuff doesn't grow there. It just doesn't. You might get a myxoma. It's on a rare occasion, but traditionally things don't grow on the intra-atrial septum. So if you see a lack of motion with material that originates from the septum, it is a PFO with material that's crossed until you prove it otherwise with imaging. It's a huge, huge point to be able to make. I actually, if I got time for a quick story.
Please.
I had actually shown up, so there's I live in Little Rock, Arkansas, and one of our practitioners is out of Memphis, Tennessee, and it's a cardiovascular surgeon, and his name's John Craig. Dr. Craig calls me and he says, Tatum, I got a case. Here's my images. What do you think? And he sent me 4 TTE images, and I said, John, I can't see the septum and I don't see movement there. Gave him the whole thing. I think it's going to be crossing a PFO. He goes, yeah. I said, can you get a better image? He said, no. I said, well, I love to drive fast. How soon will the patient be there? He said, 1 hour and 30 minutes. Now, it's 2 hours. I was hitting my mic. I'm sorry if that messed up. It's 2 hours from my house to Memphis. I made it 1 hour and 18 minutes. It's an hour and 40. I made it an hour and 18. Beat the patient there, got in, got the patient to the table. We did not open any product because I was fearful that it wasn't going to work out well. He goes over, they drop a TEE probe, and he says, Tatum, get over here. And I walked in, and sure enough, they've got the stuff which originates at the atrial septum, and going right across the septum was a piece that was large enough that you just wouldn't risk embolization. And so we make that assumption for all of the cases that happen where you have a lack of mobility in that space.
That, see, and there you go. You didn't really know, and you know what? You could have winged it, so to speak. Now, probably isn't, and you'll be okay. And then you go poking around, and that piece breaks off, and they have a big stroke, and it's over.
It's not. We don't give medical judgment, right? We don't dictate medical practice. But what we will do is when somebody asks, "Do you think this is a good case for AngioVac?" No, I don't think it's a good case for AngioVac, unless you have a way to be able to ensure that you can protect the head vessels.
Yeah.
Right coronary artery is going to be the first one that's going to go after if it goes to the heart vessels. And then what we find usually is that there's a little bit less concern. They feel like they can chase something into the mesentery or another area should it embolize there. They just want it out of where it's existing.
Man, I'll tell you what, I mean, a gut infarct is pretty bad.
It's a gut infarct is awful. But they feel that they can easier chase a gut infarct than they could chase a cerebral one.
Well, clearly. I mean, that's,
so
yes, I would agree.
when they talk about risk assessment,
you have a little more time.
Acceptable risk gets them to, and I know that the answer to that is obvious, but acceptable risk is something they're able to take in the mesentery where they're not able to take it.
Yeah. Wow. That's some scary.